Good afternoon, everybody. My name is Paul Hook. I'm the Managing Director at the Canadian Institute for Military Veteran Health Research, also known as CIMVR, here at Queen's University, and I will be your moderator today. I feel like this is kind of a reunion of sorts, as I was the moderator last year for the discussion about a tabletop exercise called Exercise Trillium Cura, both with David Pedlar and Colleen Forestier. So good afternoon and welcome to you both. Bonjour et bienvenue à tous et à vous deux. We have some time here, about an hour, to discuss a topic that is not only both interesting and timely, governing for readiness, health system leadership in an era of sustained conflict, but also extremely important to the geopolitical situation and to the world at large. So before we get into it, we'll give some audience some insight into who both of you are. And David Pedlar, PhD, former scientific director at the Canadian Institute for Military and Veteran Health Research, also former director for the Research Directorate at Veterans Affairs Canada. He's been in and around the topic of military and veteran health research and the strategic side for decades, and is an expert in his field. Currently working at the Royal as a senior scientist and as the CIMVR strategic advisor. Brigadier-General retired Colleen Forestier is currently the CEO and registrar of the Alberta, I'm going to get this wrong, Colleen.
College of Physicians and Surgeons.
There we go, the College of Physicians and Surgeons. Formerly the Deputy Commander of the Canadian Forces Health Services Group in the Canadian Armed Forces. A ton of experience operationally, tactically, and strategically, and now so lucky that she was able to transition to work in the provincial side. And so we have both of you here today. It's going to be fantastic. Just from my background, a veteran of 25 years in the Canadian Armed Forces and now a director at CIMVR. Je m'appelle Paul Hook, un vétéran de 25 ans dans l'armée. Et maintenant, je suis le directeur des opérations à l'ICR SMV. C'est un plaisir d'être ici avec vous deux. It's a pleasure to be here with both of you. I know we have dozens of people online, and hopefully this will be shared with hundreds more in the future. So without further ado, I wanted to kind of do a scene setter. I'd love to talk about what's happened in the past year and your view on the geopolitical situation that drives these type of strategic exercises. So for you two and for the audience at home, as you may have seen, US President Donald Trump announced in early May of 2026, so just last week, that he would be withdrawing military forces from Germany. So the early number being discussed is about 5,000, which would still leave 30,000 US soldiers in Germany. That's the largest number of soldiers in all of Europe for US forces. He's also suggesting pulling troops from Italy and Spain, and this is just on some disagreements about the US policy and NATO support of the war in Iran, or the special military operation, as some people are calling it. So this lack of support, quote unquote, by NATO countries has consequences, according to Trump. And it's so timely because of the tabletop exercise that we talked about, and that happened last year and in the previous year, of a potential conflict that Canada would participate in. And we all know that Canada does not go into war zones or conflicts by itself. It is a very multilateral discussion where Canada would be going in with allies and partners, notably with NATO and with the US as well. Interestingly, in the German case, Germany is also home to the Landstuhl Regional Medical Center, which is the largest American hospital outside of the continental US. And Canada used to have its own hospital in Germany. Colleen, I don't know if you remember those days, but I lived in Lahr in the 1980s and with my family while they were posted there. And then Canada ended up building a new hospital in the late 80s, early 90s, I believe. And then once Canada pulled its forces out of Germany in the mid 90s, that hospital was given back to Germany. So Canada does not have a hospital outside of the country and does not offer a military hospital at all anywhere in the world or in Canada. So these discussions about Landstuhl, about Canadian participation in NATO and U.S. Wars around the world, and support is always important when we're looking at topics like this today. And so, I mean, if we look at why this discussion really happened with the, invasion by Russia of Ukraine, we're currently seeing, I think, 30,000 um, wounded and dead by Russia every month. A number that many have said is unsustainable. And I know we'll get into the details, but your tabletop exercise looked at a very small number in comparison of casualties coming back from a potential conflict to Canada. So this just puts everything into context of where we are today. So without further ado, I know you have a fantastic presentation planned. Dave, you're going to be doing the first half and Colleen the second half. So without further ado, we'll kick off. And then at the end, we'll see if there's some nuggets that came out that we can dive deeper into. So I will turn the floor over to you, Dave.
Thank you. You can hear me okay? Yes?
Perfect.
Okay, great. So thank you, Paul. That was kind of the perfect launch introduction you gave around the content area. And Colleen and I are really thankful for the opportunity to talk to you about the title of this presentation, Stress Testing Canada's Health System for Large-Scale Combat Operations. Here, I do want to highlight our core partners in this work, which is the Canadian Armed Forces, the Dalla Lana School of Public Health, CIMVR, and Unity Health St. Michael's Hospital. Today, we focus on a program of work that started over 2 years ago. The subject is civilian military health system resilience in the context of LSCO. LSCO is an acronym. It means large-scale combat operations between near-peer adversaries, and it focuses on capabilities to fight modern standing armies. We need to recognize that health systems are actually a key capability in war. So this presentation will discuss LSCO from the Canadian and Canadian Armed Forces health systems perspective. So let me just give you a really quick lowdown on what we're going to talk about. We're going to talk about the geopolitical context because it's so important. It sets up the need and urgency for this work. Why this approach is needed for CAF personnel, and it's not the same as civilian personnel. Why we use a wargaming tabletop approach, and then we're going to present the 2 tabletop findings that were designed to stress test healthcare systems faced with a flow of Canadian Armed Forces casualties. And mentioned one is called Exercise Trillium Cura, that was provincial based on Ontario as the context. And the second was Exercise Canada Paratus, a pan-Canadian tabletop that involved both federal and provincial jurisdictions. And then we'll give you then we'll talk for a few minutes about some concluding slides. Next slide. So let's roll in and discuss a little bit about this geopolitical moment, and to get the urgency back on the table, why we think we need to act. Next slide. So as Paul mentioned, this is clearly a time of heightened global uncertainty driven by intense and concurrent geopolitical factors. And as Paul mentioned, these seem to change maybe weekly or often. Key factors driving LSCO planning among NATO members has been the full-scale Russian-Ukraine war, which has also caused a shift of focus from preparation for insurgency warfare like Afghanistan to preparation for full-scale state-on-state conflict of peer adversaries. We're also aware of the tension and focus on China and threats across the Taiwan Strait. A new war is underway in the Middle East right now involving Iran, the US, Israel, and Gulf states. There are other social, economic trends and tensions that are troubling. And another factor that Paul mentioned, which is the uncertainty and the realignment underway between Canada and the United States and NATO nations. And Canada is very involved in those relationships. In fact, a number of NATO nations have formally undertaken threat assessments. Examples are France, the UK, and Germany. For example, in 2025, the French National Threat Assessment foresees high risk of high-intensity war on the European continent by 2030, and a similar threat assessment by Germany marks 2029 as an important, between now and 2029 as important dates. Meanwhile, we have also entered a new era in battlefield care. Peer-to-peer conflict will mean preparing for large-scale mass casualties in artillery battles like we see in Russia, Ukraine. New drone warfare has changed warfare dramatically, causing more serious wounds and presenting obstacles for far forward logistical support, making for more dangerous and longer delays in critical medical evacuations. And so if you look at the literature, you'll see now it's common to hear it said that the golden hour rule to save lives in medical evacuations is actually no longer viable. So it's causing us to reset far forward care tactics and increasing patient medical complexity and reducing chances of survival post-evacuation. So this is kind of about, well, is Canada ready? And Canadian health systems, as you will know, face ongoing strain and in some cases crises with high volumes of patients, financial shortfalls, supply chain issues, and HR shortages of health professionals in different stages of concern across the country. Okay, next slide. So part of thinking about Canada's preparation really takes us to the question of how the health systems work. And Canada has what we call a mixed civilian and military healthcare system that would have to carry a very heavy load in a LISCO scenario. So if we go back to the mid-70s, following the Glasgow Commission, Canada, like most other nations, has systematically scaled back on dedicated military veteran inpatient infrastructure, transferring military and veteran health capacity, including hospital beds, to the provincial civilian sectors. Today's situation, although there are no longer military and veteran hospitals in Canada, the Canadian Armed Forces is responsible in legislation for the care for regular force CAF members, but noting that much specialist, all hospital care and a lot of mental health care is accessed through civilian healthcare systems. Canadian Armed Forces reservists also rely heavily on civilian providers. And today, over 400,000 Canadian Armed Forces veterans rely almost entirely on civilian provincial healthcare systems. And experiences over time, and in the current Veterans Affairs Canada rehabilitation program, now and in past era, tells us that service-related injuries often result in lifelong need for care and rehabilitation. So the consequences of conflict are often lifelong. So a LISCO surge will certainly present massive challenges to Canadian healthcare and provincial healthcare systems. Luckily, this status quo has worked okay in peacetime and during the war in Afghanistan, but a mass casualty situation will take us into a different space. And this is just to note that after World War I, Canada had 13,000 dedicated military hospital beds, and today we have none, and none are being created. So that's that slide. So go to the next slide, Paul. Oh, here we are. Okay. So let's take a look at, we've also learned some lessons from past conflicts and past emergency situations. So we know that Afghanistan was a dangerous 10-year-long insurgency war. 44,000 Canadians were deployed. It was the largest deployment since World War II. Approximately 2,000 were wounded and 158 killed. So how did we handle military cooperation for Afghanistan casualties? Well, the answer is we did okay. Care plans for injured military personnel relied primarily on local relationships between Canadian Armed Forces, health services, and civilian health systems in relationships developed across Canada. But it was not always easy. But here I want to highlight that there was no formal system to handle care and cooperation. But what we know is that a conventional warfare situation with near-peer adversaries in Europe or elsewhere would result in much higher rates of casualties than Afghanistan. So we have also faced other kinds of national health emergencies, Canada received international praise for its handling of SARS in 2003, but later published reviews concluded that over time, this excellent work atrophied. It was on the shelf and not continuously updated. And many lessons were learned in the COVID experience as well, but noting that a comprehensive, thorough federal review was postponed a few years ago, so still inconclusive. The findings from previous experiences are useful, but they are insufficient in depth, scope, or fit to prepare us for a LISCO scenario. But we do know there are 2,200 CAF members in Latvia right now. So we also know that this threat is real and it is immediate. Next slide. So I just want to highlight, this is a quote from Dr. Margaret Bordeaux, and Colleen and I are members of that Dr. Bordeaux-led Harvard University Threatened Health System Scholarly Working Group. In this quote, she kind of nails the problem of vulnerability by highlighting the importance of having a high-functioning and collaborating military to civilian health system. So that's what this quote is to underline. Lack of health system preparedness is the Achilles heel of NATO, that Canada and other NATO nations will become overwhelmed very quickly in a situation of large casualties. So this is a high priority subject area for to have high functioning military performance and to keep civilian systems running. Next slide. So another factor that we need to consider is that modern warfare is a unique challenge and not familiar to day-to-day civilian practice. There is overlap, of course. Modern warfare would present unique challenges to health systems that are explored at our tabletops. So, for example, I've personally been to the national rehab hospitals in Lviv, Western Ukraine, and the injury impacts on the Ukrainian battlefield are often compared to World War I. Many thousands of amputations, often same person with multiple amputations, really horrific burn injuries, complex facial reconstruction surgeries, high rates of traumatic brain injury, World War I-like severe operational stress injuries. And in ground wars, it's common to have prisoners of war, which is the case in Ukraine. So there's also treatment of special populations that include prisoners of war and victims of torture. So some of the challenges faced with this are how to keep civilian care functioning at the same time. How can you address additional emergencies like climate-related events? Large-scale military mobilization in past wars has reduced the civilian workforce at the same time. Cyber attacks are likely to target health systems. There will be unique supply chain needs and disruption. And there was supply chain risks during COVID-19 that we are familiar with around vaccines and other needed products. Next slide. So these are four, I think I'll call them framing thoughts, but let me just call these big thoughts because they help us frame the issue. And if there's a takeaway today, these could be four kind of takeaways that are worth remembering. One is that LISCO must be a priority in Canada working with NATO nations in preparation for LISCO. So we are likely to need to share the burden with multi-nation planning. Interoperability will be critical, especially early in the care chain process that Paul mentioned. And also to be aware that Canada may be required to accept foreign nationals and civilians as well. Number two, in Canada, very close civilian and health system, military health system cooperation will be essential. And in the tabletop, you'll see we've started working on this problem at all levels, governance, politically, and in supply chains. Number three, this is short but important. All threats to threaten military civilian health systems should be spelled out as a priority in Canada's national defense policy. Health is a priority and should be a priority and named so. Four, strengthening of health systems should follow an all hazards threat. a layered approach because we also recognize that we need to address other challenges like fires, pandemics, heat domes, and other emergencies that have also required close military-civilian cooperation that go back many years. Next slide. So, building on 2 years of work, we organized 2 tabletop exercises to take us deeper and deeper into these issues I've just mentioned. One exercise, Trillium Cura, was Ontario-wide simulation that lasted 2 days in response to sustained military casualties from a European conflict. And the second exercise, Canada Paratus, was a direct answer to what participants wanted after Trillium Cura, but it brought also federal and provincial participants to the table, was larger, and went for 3 days. Both exercises were designed to stress test healthcare systems under large-scale combat operations, LSCO, from casualties in Europe, to identify critical gaps in system capacity and governance, to improve crisis response planning and interagency relationships, and to maintain civilian access to care while managing repatriated casualties. So this is really obviously a very serious subject matter. Canadians, including the healthcare community, are becoming increasingly aware that we face a heightened global threat posture. But we also need that more attention is needed to domestically prepare health systems for this kind of long-term conventional war engagement. If it happened tomorrow, we'd have a lot of trouble on our hands. So here are just a few key questions, and I'll just go over these quickly because different players in the healthcare system conceptualize what the issues are more selectively. So here's just some broad ones. You have to know how health system financing will work under wartime economic conditions. Is healthcare leadership and governance designed to manage sustained emergencies across jurisdictions? Are health information systems vulnerable to enemy-sponsored cyber attacks? IT, administration, disease surveillance, patient records, connectivity between civilian and military information systems. These would be critical during a time of crisis. Would the workforce be able to serve both civilian and military needs simultaneously? So this has been a problem in past conflicts in Canada, World War II, for example. And is the system prepared to treat the diversity of injuries expected in modern conflict? Some of those I highlighted a few minutes ago. So next slide. Methodology. And go to the next slide. So I'm just going to cover this very quickly. It's just to highlight that tabletop exercises are important. They provide a highly collaborative environment to develop and test response plans, build critical relationships, and identify the gaps before a crisis occurs. And they are used frequently in military settings, but also frequently in civilian health planning settings. So it's not a new methodology. And a major advantage is that they often uncover things that would be left unrealized using other approaches because they bring, a diverse group of players together. So in our these exercises, we brought both military and civilian sectors together and provincial and federal government players. So next slide. So again, this is just high-level coverage of this, but wanted to make you aware with the visual representation of the long and complex medical chain that would be required to move casualties from Europe. In the context of a European-based LSCO, there are many other layers involved in supporting casualties overseas and the logistics of getting casualties back to Canada. Our tabletop represents really the tail end of that path, and also the more definitive long-term care of complex casualty logistics. Most military assets would be committed to other and more front-end portions of this complex chain, hence highlighting the importance of bringing healthcare and government leaders together in this planning space when they, in this case, where they return to Canada. So that's my portion of the presentation, and I'm thrilled to be able to pass it over to my great colleague, Colleen.
Thank you, David. Thank you for setting the stage. And for this next part of this presentation, I'll be digging into a little bit more about the specifics of each of the war games, both Exercise Trillium Cura and Exercise Canada Paratus. Given the relatively short time we have today to go into this, we'll be really just touching on the wave tops, understanding that in the presentation and certainly available publicly are the links to the actual reports for both these exercises, which provide quite a lot more detail. So we'll initiate this with a little discussion around Exercise Trillium Cura that was done in 2024. And that one was a 2-day exercise. And again, from a war game perspective, this was rather unique. It was the first TTX or tabletop exercise of its kind. Forgive my acronyms. I haven't gotten out of my military acronym habit yet. This was the first TTX of its kind for the Canadian Forces as well as for health system leaders. And that's because we were using a gamification process to really shift a little bit how we think of tabletop exercises and how we engage those who are involved. It took more than 6 months of planning to bring it together and relied heavily on relationships that Dalla School of Public Health had, as well as private donors and Canadian Armed Forces wargamers to put together. Our wargamers had never planned anything quite like this in the medical evacuation space or even in the healthcare space, and took on the challenge with incredible thoughtfulness and curiosity. And it didn't take long in the planning phase to recognize the limitations we would face. Limitations in time, limitations in strategic and operational scope, and getting the right people to the table. The exercise itself featured roughly 45 participants and 27 observers, and senior leaders from across Ontario, from across provinces and territories as observers, and individuals from administrators, academics, media, Canadian Armed Forces planners and members of the health services teams, and a number of other participants. The goal of this exercise was simply to simulate the sustained flow of less than 50 casualties per week. So on its surface, it didn't look like a lot. But when you sustain that number over weeks and weeks and months, in an existing fragile healthcare system, you start to see and you start to be able to really unpack what the challenges may be, not just at the acute care side, but actually at the tail end and the rehab and impacts on home care and all of the other long-term care requirements of casualties. In this iteration, it was deliberate to keep it to Ontario only because we felt that getting into the multi-jurisdictional landscape would be a little bit too complex at this stage, and so we focused really on the Ontario jurisdiction only, and even there unpacked quite a lot of complexity. You can see there on the bottom that's the link for the report if you'd like to go into that a little bit more. But next slide, we'll go into the key findings. So the key findings are really just identified here in two broad components. One was governance and operations, and the other one is capacity and resources. And the key findings really were on the governance focus was that there were the authorities, responsibilities, and clarity of decision making were in our current frameworks were not really designed for sustained non-jurisdictional crises. There was a clear individual commitment and personal commitments across the board, but without those frameworks and infrastructure and policy, that is not sustainable in the long run. We identified a significant difficulty in data sharing and data sharing capacity between military and civilian systems, but even then between inter-civilian systems. and a broad awareness of the dependencies on U.S. and other allies for specialized items like burn care, burn grafts, blood products, and the limitations we had in our medical supply chain as a result. And those vulnerabilities were really highlighted. Uh, the importance of civilian and military relationships was highlighted as well, understanding what the capacity and limitations of each of those systems were and how they function was incredibly important and a real valuable piece of this particular exercise. Next slide. What was also really interesting is that it really highlighted that the COVID-19 response framework in and of itself, which is what the leadership teams initially leaned back on at the beginning of the exercise, was insufficient. And it was insufficient because the casualties were coming from an external source, that the complexity and the needs were slightly different, and the ability to sustain that requirement over a long period of time really required something a little bit different than what the COVID-19 framework had presented. We identified unresolved governance and supply chain issues, as I've mentioned previously, and the relationship benefits of these tabletop exercises and wargaming in general. One of the successes that came out of this is it really highlighted and provided a clear focus on Canadian Blood Services requirements. And there was investment as a result of that into looking at skin graft resourcing and blood donor systems, freeze-dried plasma investment as well. And so that work was pushed forward a little bit as a result of this exercise. But one of the key recommendations was that this needed to be scaled higher. So the discussions around governance in a jurisdiction like Ontario highlighted the need for even high level discussion around governance in a pan-Canadian context. Next slide. Which brings us to exercise Canada Paratus. Next slide. Because of the significant amount of discussion after exercise Trillium Cura and an increasing awareness of the importance of this type of planning and relationship building work, it was really important to leverage the momentum we had and bring a national lens to the table, which is what this exercise was all about. This one was 3 days, also a strategy level wargaming exercise held in September 2025 at Unity Health in Toronto and hosted once again by the Dalla Lana School of Public Health and Unity Health. There were 79 participants and observers, this time from every province and territory, and a significant amount of participation also from our Canadian Armed Forces personnel and health services teams. Again, participants you can see there from across different sectors. It wasn't limited to just health sectors. And in this case, it simulated casualty loads that doubled from exercise Trillium Cura, 100 casualties per week. But the idea was to distribute this casualty load across the country rather than just into one jurisdiction. And that was a little bit of a shift and resulted in some really intense conversations about how that would work, who would distribute, who would be the decision maker in terms of how the casualties flowed across the country in an already fragile healthcare system. We did not wash away the fact that the healthcare systems are currently at capacity or over capacity. We had to integrate that into the planning. It also touched on some added dimensions that exercise Trillium Cura that could not address and touched on, and I say just touched on, captured personnel, strategic airlift and sea lift requirements, national scale civilian military police policy tensions, and long-term rehabilitation and mental health considerations for casualties. Once again, you'll see the link there at the bottom of the page if you're interested in reading the more fulsome report. Like exercise Trillium Cura, it modeled the real healthcare system capacity And although the complexities were introduced, many of these issues were not able to be meaningfully explored at the operational or tactical level. I think we highlighted the fact that there are limitations in time and capacity, and with such a large number of people at the table, we really did highlight and focus on the policy and federal governance frameworks, and it made it difficult to go into the next layers. So those were the dimensions that I've mentioned already, and just highlighted here on the other items that were touched on in our discussions around Exercise Canada Paratus. The key findings, and I've mentioned this a couple times before, is not surprisingly, the key findings for Exercise Canada Paratus had many similar findings to Trillium Cura. And a lack of a pan-Canadian governance structure for managing a sustained mass casualty crisis really highlighted and created some of the additional challenges as we worked our way through the exercise. And when you look at Canadian governance structure for any kind of crisis, it often falls on public safety to manage those. But health care and health systems are not often at the table. And so, how do you bring health systems and health crises to the public safety governance structure and not as an afterthought or not as a Health Canada will manage this kind of space? How do you actually encompass this as viewing health systems as a national security asset and bringing health system and health system capacity and considerations to the public safety forefront? The top recommendation was a creation of a federal, provincial, territorial health system and emergency and security table with specifically identified lead agencies, trigger points, a peacetime mandate for planning and rehearsal, and an important in the importance of clear and consistent communications. That ambiguity, when you have leadership and governance ambiguity, creates vulnerability in all of the areas. And I'll caveat this by saying it is recognized that one of the real challenges with this type of preparedness planning and work in a strained system is that it takes time, resources, and expertise to sustain. And these are aggravated by jurisdictional considerations when it comes to health and health management and health delivery. It also is aggravated by government department staff turnover at all levels and funding challenges. Next. So the Exercise Canada Paratus key findings highlight what the Exercise Trillium Cura gaps were and what the recommendations from Exercise Canada Paratus were. So moving from the identified gaps, confirmation of those gaps, and now what are the recommendations to move that stuff forward? And so identifying the trauma registry, once again, the need to be able to communicate effectively about the care of casualties from the time of injury until and within the systems once they arrive back in Canada is imperative for quality improvement and quality assurance. The burn care gaps domestically, blood supply concerns, and identifying opportunities to enhance the way in which AI can be leveraged to improve both care and triage systems. The one area we were not able to, well, multiple areas we weren't able to get to, we wish we had, was really looking at mental health at scale. Mental health systems were identified as a core requirement to dig into a little bit more, but we just didn't have the capacity in the days that and the limitations of the exercise itself. But to look at mental health and addictions, mental health requirements, trauma-informed care, centers of excellence to provide that care in and after a conflict was highlighted and is much needed, and that that will probably be it is likely to be the focus of some follow-on work as a result. Next slide. What Exercise Trillium Cura and Exercise Canada Paratus really produced, though, were measurable improvements in the participants' understanding of their own roles, their partner organizations' roles, and capacities and limitations. And this was probably the most important work that was done. How do you bring people to the table that will actually be able to work together in the future or during a crisis and develop those relationships and invest in those relationships? We demonstrated how civilian and military health systems are a significant aspect of defense and security in those conversations and in the requirements of casualty flow. And I would highlight here also the importance of using a layered series of TTXs. We were able to focus in those initial 2 days and then the follow-on 3 days, really on what the governance framework would look like in terms of movement of casualties, the financial management of casualties, and the strategic airlift. But what we weren't able to get into is what does that next layer look like? Movement from acute care into rehabilitation, the mobilization of civilian infrastructures for mental health, supply chain management, and other elements. And I think we've identified the opportunity for those teams to take that first layer of work and then continue to work it through at their operational or their focus level and continue the work in their own domains. The other thing it highlighted was that developing a culture of wargaming and tabletop exercises as a normal organizational function is really critical. As David mentioned, the atrophy of the SARS reports and the SARS work sort of highlights the fact that we in our Canadian healthcare system don't tend to consider or invest in the importance of tabletop exercise to keep things current, to ensure they're fit for purpose, and to bring our teammates, particularly new teammates, to the table to have some of these hard discussions about how the system can and cannot function in its current form. So the path forward, next. Let's highlight a couple of them here. Establishing a federal, provincial, territorial health emergency and security table would really move some of this work forward. Continue the conversations around tabletop exercise and planning. I think we really need to have some important conversations about what that financial framework to sustain cross-jurisdictional health needs would be, and included in that would be investment into IT and information management structures. And then the layered considerations for additional tabletop exercise arms for non-acute parts of the healthcare system, leveraging the work of Exercise Trillium Cura, Exercise Canada Paratus into rehabilitation, home care, mental health and addictions, and social supports to create additional layers of understanding of what the policy gaps and capacity gaps are. Next slide. I think we're almost at the end here. The strategic imperative here that both David and I really wanted to highlight is this idea of joint military civilian health systems as a national security asset. There is a reason that Russia targets healthcare infrastructure, and they did so in Syria, they've done so in Ukraine, is because it's demoralizing and because it erodes resilience of any kind of social system. So if we look at health systems from that perspective, it really does provide a framework that highlights the need to invest in ongoing tabletop exercises and defense policy updates. Looking at this from an all hazards approach, this isn't just about LISCO. LISCO is one of many hazards, and we need to be looking at health integration to strengthen the system against many hazards so that this improves the health system at large. Our NATO obligations here are that we are an ally. Our NATO nations are actually planning for LISCO and preparing their health systems already. We have an obligation to do the same. And from a moral duty perspective, this highlights those that we need to be ready for those who step up and serve Canadians overseas and elsewhere to ensure that we're ready to look after them in the way that they deserve to be looked after. Next slide. So I just say thank you for your attention, and I'll hand this back over to Paul for any questions or any additional commentary that this might have triggered. Thanks.
Perfect. And thank you to you both. I will we have a couple of dozen people here online. So if you want to put a question in the chat, feel free. I will say that having been in the military, Colleen, the joke is that the Canadian military always prepares for the past war, the past battle. And I think what's important about the points you both brought up is that this tabletop exercise, when looking at the COVID-19 response framework, that was the first step. You go with what you're comfortable with. You go with what has recently been proven to be successful, and we know that it didn't work. So the fact that the tabletop exercise was able to be an iterative approach to go from the 2024 just in Ontario, taking off a small chunk, and then looking at the silos that need to be broken down, going into 2025, doing Canada Paratus as a tabletop, large scale planning, large scale combat operations. I thought it was fantastic in the points you brought up, because the first four things that came to my mind: cyber attacks, disinformation, a stressed healthcare system, and who gets care first. Like if we look at 13 provinces and territories plus a federal system, then you've got wounded individuals who may get sent to a province based on the triage system that either A, they're not from originally, or B, their family's not living there. How do you end up making all of those decisions? How do you keep the system from being attacked from our adversaries? How does the messaging happen from different provincial healthcare and premiers and territorial governments? If who gets care first, who's more important, how are we going to make sure this system works? And then, Colleen, as you brought up, the recommendations that come out of this, it's great if the war is going on right now and in that planning is top of mind. But if yesterday or the day before, Vladimir Putin spoke about this little nugget that maybe it's time to end the war in Ukraine, what were to happen if that took place? Canadian resolve and planning for future tends to be very myopic. It's like at the edge of our nose. And then we go, it's not a big deal. We'll just cut everything. But I think the recommendations that you both spoke about that came out of these tabletops leave everybody wanting to do more, knowing that we can do more. And then I think a question I'll ask both of you is, looking at some of the recommendations about blood supply, about how this could further advance not only military but civilian healthcare systems. Where do we look at this from the Defense Industrial Strategy and then Defense Investment Agency and Canada's 2% or 5% for NATO spending? How do we as a group look at the government, the federal government and provincial governments, go, this can benefit not just the Canadian Armed Forces and the healthcare system, but it can benefit so much more from a private industry, healthcare, innovation, research and development, and everything else. So what do you see in that aspect?
Okay, I can start, David. I don't know if you have anything else to add. Oh, there's so many questions there. So I'll focus on sort of the 2% and the investment piece. I think I know Canadian Forces Health Services has really been sort of leaning into that and trying to highlight. I think the agility of the Canadian Armed Forces to sort of from an investment perspective is in healthcare in general, and I want to think like investment in things like supply chain and research and experimentation. And when I say experimentation, I'm thinking like, drones and capacity in that space. Um, is hopefully becoming more agile. I've been out since September. I've retired since September, so I don't know what's changed since then. But I do know that there is a great deal of identified possibility, and the system itself needs some adaptation and some adaptation in terms of being acceptable risk and investment into those spaces. But I would see so much opportunity in the medical supply chain domain,
Hmm.
the stockpiling, um, to think differently about things like northern infrastructure and dual purpose infrastructure, particularly in the Arctic and like those are areas that benefit both the civilian system and the military system, and that dual purpose space and capacity building has quite a lot of possibilities. It's just actually getting it initiating and getting it started, or sustaining it in the long haul. That will be interesting to see how it plays out. And I want to caveat that, sort of saying again, I'm not in the know. So I'm doing this based on sort of my current understanding of the situation. So
Excellent. I think that ties into Nicholas's question. So did the study generate any numbers to quantify how bad the situation is? So excess mortality due to resource and organizational constraints, or, looking at the political will to change, you would need to estimate the numbers of soldiers dying unnecessarily. So I think that if either of you have any answer for that great question, it'd be wonderful.
This is Dave. I was going to answer the first question, and
Oh, sure, go ahead.
just if I may. So I'm actually working on a list right now of the Canadian companies. So first of all, this kind of war and most wars have been really a hot spot for innovation. And a lot of emergency medicine has really been informed by tactical wartime medicine, especially under high strain, like we see in Ukraine right now. So I'm actually working with people in the Ukrainian community right now to make a list of the innovations in health technology going on in Canada with Canadian companies that are working with Ukraine. So a lot of them are tactical medicine, point of care, things like, for example, being able to do ultrasound at the point of injury. And so there's a whole series of devices and things that are actually in use now, but they're collaborations between Canada and Ukraine. So I
Wow.
think so I'm actually looking at that list, and I wrote Nick this morning and told him I'm going to send him the list. So I think that getting on top of the innovation would be critical for trying to make decisions around how to support this kind of activity, which can have a lot of relevance historically for civilian medicine as well,
Okay.
especially urgent care.
And Colleen, do you want to answer the question here about the numbers, how bad the situation was?
I don't know if David has anything else, but I don't know that we got like I don't recall getting into that layer of granularity. I think we would when we were doing the tabletop exercise, it became quickly evident that the even the use of the 50 numbers and like getting into the actual the impact of something like medical supply chain or burn grafts or limitations in that in terms of unexpected or preventable deaths. We didn't get into that layer of granularity in the sort of algorithm or calculations. It was really grosso modo,
Okay.
this is going to be a problem. We don't have enough burn beds. Where are we going to send them next? There's not enough. And by the way, do we realize only 10% of burn grafts actually come domestically, and we rely on 90% for them from coming externally?
Wow.
Things like that were part of the discussion. but not necessarily specifics around the numbers. In the war game itself, there were not random things, but there were elements sort of thrown in there, like an unexpected outbreak. And that was the beauty of the war game. These things were being thrown at the players in such a way that it created necessary conversations in a gamification kind of way that wouldn't have been generated had the TTX or the scenario or the vignette just played out as a usual vignette. By throwing in some of these other elements, it created conversation, but it didn't create specific calculations of what was being asked there in the question.
Okay. So to tie into that, if I know Francis asked a question, and maybe Dave, you can answer this. Um, did Canada collaborate with other countries to inform the planning for the second exercise? And once the report came out, has there been discussion with NATO allies for the lessons learned, lessons identified, and future operations or tabletops?
Yeah, so the answer is yes. And so, for example, at the Paratus event, we brought in Margaret Bordeaux as our keynote speaker from Harvard, who's informed some of the dimensions of this. Actually, widened the dimensions of how to think about this in the planning for Paratus. And then there's ongoing work, especially if we do another one. So I'm working with King's College right now. The Australians and the UK are both sort of up to their necks in this kind of work. So there's been some contact with the UK, but we're all at different stages of doing this work. So I'm hoping to bring some of the players together to have some virtual calls to find out where everybody is. So I have a call with Margaret Bordeaux's team tomorrow, for example, because they're doing NATO work right now
Right.
at the NATO level on this issue. So it would be great to see their drafts of what they're working on to help inform the Canadian work and the planning we're doing for another tabletop that we hope will take place late in 2026.
Okay. And then I know Rebecca's got a question here. While understanding the reasons for avoiding interjurisdictional questions in your exercise, how would you recommend that a federal, provincial, territorial group address the constitutional division of responsibility? So that's a good question, especially if we look at provincial healthcare and the CAF having a federal, quasi-federal healthcare issue, and then looking at emergency management. So how would you answer that one? Colleen, I can
Yeah,
see you
I'll kick it
smiling.
off.
It's a
It's like,
difficult
oh,
one.
that's a yeah, that's a doozy. And I think the beauty of the Ontario one, Exercise Trail and Curio, which was the first one, is in order we needed to walk before we ran. And we to be honest, also, we didn't have a lot of federal participation or interest in the first exercise. So to be able to create it and focus specifically on the Ontario context, provide us the opportunity to really sort of talk through and identify some of the gaps. But of course, one of those gaps was, okay, well, if these are coming in and we can't take anymore, who decides where they go? And that sort of created, we really need to have a national framework. But you're exactly right. This by bringing the P's and T's to the table, we start these really important conversations where Saskatchewan, and that also highlights what is the financial framework for this? Who's going to pay for the casualties coming in if they aren't actually from that province or from that territory? And the need to distribute casualties, who all of which are federal, across the country. What does that look like? And so the first part of it is establishing that federal framework by which you know who directs it and who has the authority to direct where casualties will go, how the finances will follow that particular casualty to make sure that jurisdiction receives appropriate compensation to support. And then on top of that, creating the necessary relationships between provinces and territories so that those individuals and those leaders are at the table identifying how they can support and in which capacity. Maybe the territories don't have a lot of capacity for burn care, but maybe there's another capacity we can leverage through their frameworks. So I think it really kind of highlights the complexity of that jurisdictional space and the importance of actually creating the table at which these conversations happen, and
Yeah.
health it has to be at the table, not an afterthought. And I think that's where it becomes super important, and one of the findings that and something we want to continue to invest in and develop.
Okay. So, Dave, I know we could talk about this for another hour. I'm going
Yeah,
to
sure,
ask
sure.
for one takeaway from each of you. And Colleen, I know you're answering Genevieve's question online there, but Dave, what's one takeaway? Where are you excited for the next tabletop, or what do you see that gains the greatest benefit for this for Canada, the health system, and the Canadian Armed Forces?
Well, for at least 2 to 3 years, I thought this is really a high area of risk. I'm personally motivated on this topic. You know, I live in an area of Kingston. You live on the other side of Highway 15. I know that's filled with military members, and most of them have kids who are serving and living on base. So for me, this is really a tactile issue. These people could be at risk, and that we really have to look at it as a real risk. So I do think that this is increased in profile over and priority over the last few years. But I really would like to see health spelled out as an issue of national security. I think that would put it on the radar for everyone, and we could look at different levels of what that means. And the FPT table would be a great starting point to make this a priority.
Fantastic. And Colleen?
I think developing that culture of investment into this type of participating in TTXs, not as an afterthought, not as a I can't go, and then the person I identified to go, and then they identified someone, and it just sort of trickles down. But at the true leadership level, investing in the importance of continuing these conversations and TTXs in general, and the wargaming is a great way to do that, where you're developing the relationships, but also keeping things fit for purpose, and that these conversations continue, and it actually elevates the resilience of the entire system as a result.
That's fantastic. Yeah, I couldn't agree more with both of you. It's a tactile issue, and if we don't invest now, what's going to happen later? And I mean, the ounce of prevention is better than a pound of cure is so apt in this in every aspect, because you know Canada hasn't been in a large scale combat situation since World War II. I mean, even in Korea, most of it was based within Korea for soldiers, and having the system that we have now isn't what we had during the Korean conflict or World War II or World War One. So with no federal healthcare system, we have to change the way we're thinking. And I think, as Colleen said, keeping this at the front of mind, keeping the leaders at the tip of the planning, having people invested, and investing the financial and human resources into this on an annual basis, or even at a greater frequency, is important for what we're talking about now and the potential for Canada to be in conflict in the future. So thank you both. Thank you to everybody that asked a question and that logged in today. This has been a great conversation, and it is not the end. It is the middle of the middle, I would say, not even the middle of the end. So we'll continue doing these webinars for future tabletop exercises. And thanks to CIDP for hosting us today. It's been wonderful. So thank you, everybody.
Thanks for being a great moderator, Paul.
Yeah.
My pleasure.
Thanks,
This has been a
everybody.
great topic.